So we're going to spend a few minutes going over hip arthritis, hip replacement, and what an anterior approach is and how it differentiates from other procedures for hip replacement. So I've got a few models here that we're going to use to do this, as well as some x-rays to explain to you what hip arthritis is. So the hip, on this x-ray you can see the hip is a ball and socket joint, and I use this x-ray in particular because this patient has already had a right hip replacement and the left hip is in need of a replacement. The top of the femur is a ball and the acetabulum or the pelvis is a socket, so it's a ball and socket joint. So on this plastic model, what you can see is the top of the femoral head is covered in this smooth white cartilage. It's got a bit of a blue hue in this model just to show, but this is what a hip joint looks like. So it's the top of the femur and it articulates or forms a ball and socket joint with the pelvis. Over time, what happens with wear and tear and age and arthritis developing in the hip, it's like tires on your car. Eventually you wear the tires out. Well, you wear the cartilage out in your hip joint as well. This is typically what an arthritic hip will look like. You can see there's cracks and fissures in the cartilage. There's some extra bone spurs around the edge of the socket. It's like having two pieces of sandpaper rub on each other, and that's when you start to lose the joint space. When the joint space is completely gone, which you can see in this x-ray, the two bones are touching. Normally there's 3 or 4 millimeters of space between the ball and the socket in a normal hip, but when the hip becomes arthritic and you're bone on bone, that's typically when we have to do a hip replacement. So what does a hip replacement involve? A hip replacement is to put in an artificial hip joint. So we literally go in and we excise the head. So we take a saw and we cut off the femoral head. That goes away. And then we put a stem in the femur, a cup in the socket, and then a ball to go in that socket. Hip replacements have been done for decades, and it's a very, very successful replacement. It's a great operation where people get their lives back. There's different ways to get in and out of the hip joint. This model shows what the x-ray shows, which is basically the parts of the hip replacement that go into the bone itself. So there's basically a titanium stem that goes down into the center of the femur. So inside the femur is a hollow tube of bone, and that stem gets pushed down into the center of the bone, and there's a coating on this titanium stem that actually grows into the bone. So this will eventually become part of the skeleton of the femur. Likewise, there's also a cup that goes into the socket. So what happens in a stepwise approach, basically the surgeon goes in, gets access to the hip joint, and we're going to talk about how different ways get access to the hip joint. We go into the hip joint, we take a saw, we remove the femoral head. Then we prepare the socket or the acetabulum. So we literally have these hemispherical type cheese graters, which are called reamers, and we put those on power and ream away the old cartilage, the old bone, take the bone spurs away, and they come in 2 millimeter increments. So it's a very precise technique. We use x-ray guidance when we're in there to make sure we have the proper size and position of the reamer. And then what happens is if you see these cups actually have a titanium cup with a coating on it that's almost like coral, so it's fairly porous. It's like sandpaper. So what happens is after we pick the final size reamer that fits your socket size, it's usually 1 millimeter smaller than the actual cup. And then as a surgeon, we basically hammer this cup into the pelvis. Now this is 1 millimeter bigger than the last reamer, so it grabs onto the bone, and like you see here, it's sitting down in the pelvis. So that's the cup portion of it. Once we finish the cup side, we then go on to the femur. And the way that works with the anterior approach, which I'll come back to in a minute, is any hip replacement, basically the surgeon puts a stem down the center of the femur. So we have 10 or 12 different sizes of wedges. We take these wedges and we have these broaches, which are the same size as the actual stem itself. And they start small at a size 0 and go all the way up to a size 9. And for each particular patient, you might have a different size internal dimension of your femur. So we tap these broaches in and out until we find the perfect size for the internal dimension of the femur. And then we basically put the stem in, and the same logic applies for the stem. In a press fit situation, there's a coating on this stem as well. And that stem will get literally hammered into the bone, and over 6 or 8 weeks, it will grow onto the bone and become solid. So effectively, these two titanium pieces, after 4 to 8 weeks, will literally bond to your skeleton and become part of your anatomy. Now the other part of the equation is the head and the liner. So this is just a model. This shows a metal ball, but we actually use ceramic balls in most people because it has better wear characteristics. Inside this cup goes a plastic liner. So what effectively happens after we put the 2 titanium pieces in, we take overlapping x-rays and we look at your geography. We look at how wide your pelvis is, how long your leg is, and then we have different trial heads that are plastic, and the heads come in different sizes, -4 millimeters, 0, +4, +8. So we'll put a plastic trial head in, we'll take an x-ray and overlap it and see if it's the right size, the right length. We'll check your soft tissue tension and decide if it's too tight or too loose, and then we can fine tune it for your anatomy. But the end result is you end up with a ceramic ball on the stem that couples to a plastic liner that locks into the hip replacement, and this becomes the new ball and socket. So instead of having a rusty ball and a rusty socket, which I tell all my patients where your hip is very stiff and painful like this one would be, you now have this new motion, no pain, good range of motion, and excellent function. And all that can be done with a hip replacement. Now there's different ways of skinning the cat. Traditionally, hip replacements have been done through either a posterior approach or a lateral approach. And I'm going to use this other model to explain some anatomy to you about the hip joint. So I'm going to bring in this model that has some muscles on it. And this is basically a pelvis model with all the big muscles around the front of this hip joint. And you can see on the other side where the muscles have been removed, to get this hip replacement in, you have to pick a path somewhere to get into the hip joint. Now, if we look at it from the side, historically, most surgeons have done a posterior approach. Now, what a posterior approach means, there's 2 basic approaches that were used historically, posterior and lateral. Both incisions are typically made here over the glute muscle, over the side of the hip. The patient is usually lying on their side, and the surgeon does an incision over the side of the hip and then goes down and cuts through various muscles and tendons. In the posterior approach, and this is your gluteus muscle, I'll just move this out of the way. This model allows us to do this. When we move the gluteus muscle out of the way, you can see this is glute max, so it's one of the biggest muscles in your body. In the posterior approach, this gluteus medius and minimus tendon, those are big, strong muscles that help abduct the hip. Surgeons, through a posterior approach, will actually go behind those and cut the small rotators at the back. So there's some evidence of these rotators here. Those muscles will actually get divided through the back, so they basically pick the back pathway, if you will, to the back of the hip joint. That's a traditional posterior approach. Now, those aren't very big muscles and tendons that they cut, but they are still cutting muscles and tendons. That's one downside of the approach. The other downside of the posterior approach is that it creates a path of low resistance. If you cut the muscles and tendons at the back of the hip joint, there's now an area of weakness where if the patient historically flexes their hip up too much in the first few months, they'll dislocate their hip out the back. So one of the challenges in hip replacement is avoiding dislocating your artificial hip joint, which you can imagine would hurt a lot. So one of the reasons we moved to anterior approach, and we'll come back to some of the benefits in a minute, but if you go through the back and cut the muscles and tendons in the posterior approach, the theoretical disadvantage is you're cutting muscles and tendons and you're creating some instability at the back of the hip joint. The other approach, the lateral approach, is a little bit more barbaric in my opinion, because they come in and they actually cut a portion of the big tendons of gluteus medius and minimus, which are the big powerful abductors that attach onto the bone. And if you cut those muscle and tendons, it can cause a lot of pain post-operatively. It can cause patients to limp for a while, and it's just less fun for the patients to recover, frankly. So we haven't done a lateral or posterior approach since 2004. We moved to the anterior approach for a number of reasons. The anterior approach takes advantage of a natural intermuscular plane that sits at the front of the hip joint here. So there's a muscle here called tensor fascia lata that runs down and becomes contiguous with your iliotibial band. Then there's also muscles here, your rectus and your sartorius, that run longitudinally here at the front. What you can see on this model, which is just like real life, is there's a natural plane here at the front of the hip. So the muscles run longitudinally. So literally what happens is we can spread that interval open, get in and out of the hip joint without cutting any muscles or tendons. So it's less invasive, there's less pain, less blood loss, and most patients get it because it's common sense. If you don't cut any muscles or tendons, it hurts less, it bleeds less, and you get faster return of function and better recovery. So we've been doing all of our hips this way since 2004, so we have a tremendous amount of experience. We've actually expanded the indications of this approach where we can actually do redos through this approach. So we'll actually have patients who have had hip replacements done 10, 15, 20 years ago through an old-fashioned, what I call old-fashioned conventional approach. And they'll come in and the hip will be failed, different parts will need to be changed, and we will actually go in through the front and redo the hip through the front where we don't cut muscles and tendons. And patients who have had that done have literally told us that the redo surgery or the revision surgery was easier than the initial surgery, which is almost unheard of because it's a big redo surgery when we do it. So we take advantage of the natural plane at the front of the hip joint. There's nerves and muscles that run in bundles, so we don't violate any of those principles. The other advantage for us, besides the fact that it's less invasive and you're taking advantage of the anatomy at the front of the hip, is patients are on a flat table lying on their back, and it's very conducive to x-ray. So what happens during the procedure is, as I told you, once I put the stem in and the cup in, I have an x-ray in the room, and I can look at the x-ray machine and I can step on a pedal, and at the start of the case, for example, in this hip, I'd take an x-ray, I'd put that up on the screen, and my assistants in the room would draw all these landmarks around the pelvis and around the hip joint. We use that as a frame of reference. Before I go into surgery, I measure your leg lengths and I check and see, and I write on my x-ray, you know, this patient might be a few millimeters short on that side. I put the titanium parts in, I put my plastic trial in, and then I take another x-ray in the operating room. So the nice thing about using x-ray in the operating room at the time of the procedure is we get it right the first time, the parts are sized and positioned properly, and then I can fine-tune your leg length and your offset by looking at a real live fluoro x-ray in the operating room to make sure it's done right every time. And that's a huge advantage for surgeons. It's also a big advantage for surgeons when they're learning how to do this, and we've taught surgeons all over the world how to do this technique. And it's a different position. The patient, instead of being on their side, is flat on their back. So the visual spatial relationships changes for surgeons who are used to doing this operation on their side. So really beneficial. We do almost all of these hip replacements with spinal or local anesthesia, so people are frozen from the waist down. You're technically awake, but no one wants to be awake and hearing what we're doing in the operating room, so we give you a bit of sedation so you drift off to sleep. And we typically put these hips in 45 minutes to an hour, and patients are up walking a few short hours after surgery. And at least 50% of our hip replacements currently are being done at same-day surgery centers where people will walk out of the surgery center the same day and go home and sleep in their own bed. So it's really come a long way. We are super excited about anterior hip replacement, very passionate about teaching other surgeons how to do this. And if you read our patient testimonials, you'll see that patients really recover quite quickly. The last thing I'll say about that is one of the potential downsides of anterior hip replacement is people feel so good so fast that you have to remind them that you can't rush biology. So what I tell folks is, look, you just had a hip replacement, and after 2 or 3 weeks, they're virtually pain-free, and they want to go out and get their life back because they've been miserable for so long. They'll go out and start to work out or hike or do too much. We actually have to remind you to hold yourself back a little bit. What I was talking about with the bony ingrowth, here's the way to think about it. If you break your arm and I put you in a cast, it's going to take 6 or 8 weeks for the bone to knit together. The same is true with these titanium implants. It's going to take 6 or 8 weeks for the titanium implants to grow into the bone and become solid. So if you were to go out and do too much, do some heavy squats or running or jumping or something ill-advised, you could potentially do some damage to your hip because the bone hasn't grown onto the implant yet. So it's an amazing approach. People recover quickly, but you can't accelerate biology, so you need to give me 6 weeks of being patient. And the return on investment will be hopefully a hip that lasts you 25 or 30 years.